and MD from Darbhanga University. He is a trained and fellow in cardiology. He is having keen interest in echocardiography and cardiac pacing. He has already completed more than 500 cases of cardiac pacing. He is a postgraduate teacher and guide in DNB students. Recently, he was invited on Doordarshan TV as a guest expert for heart discussion on congestive cardiac failure. Now, I request my co-chairperson, Dr. Alok Majumdar, to introduce the subject.
Good morning, ladies and gentlemen. Pacemakers, when implanted, have always been very close to the human heart. But the subject of pacemaker is very close to my heart. In fact, it is in this hospital in 1988, 25 years back, when I had implanted my first pacemaker under the supervision of Dr. K.K. Ghosh, whom I can see on the audience. My regards to you, sir. Pacemakers, like every one of us, have matured and grown in time. Pacemakers also have grown in the last 55 years in its history. It started off with a simple tool to deliver a shock to the heart, an impulse to the heart, for the heart to beat. But as of now, a pacemaker is a very sophisticated computer. It can mimic the human heart as closely as possible in its conduction pathway and also in its ability to represent human physiology. There are various other functions of the pacemakers which I'm sure Dr. B.N. Jha would be elaborating to all of us. So I think I ask Dr. Jha to start his talk.
Thank you, sir. Thank you, Dr. Shah, and thank you, Dr. Majumdar, sir. Very nice to talk in front of the learned audience, my seniors, and of course Dr. Ghosh is here. Friends, basically, do you know heartbeat? Yeah. Okay.
Please point to that side. That is it. No. There is your sensor.
Yeah. 70 per minute, 4,200 hours, 1 lakhs per day, and if somebody will live in 72 years, approximately 2 Arabs times heart is beating. And you know, cardiac muscles have a unique property that it stops only once people have died. So this rhythmicity is basically, this heartbeat is a unique feature and it is a sign of life. But all of we see, suddenly notice that heart is pulse rate on routine examination 40, 35, 28, even 20 people are coming to you. So basically this, we know the ventricle and the atria, they continuously feature that there is a typical, I always used to say the God engineers as the best engineers, that how good it is the contractibility between two ventricle, 2 atria, each second maintaining, hemodynamics, power, everything is maintaining. If this synchrony is damaged, what to do? Since last 50 years of this technology development and innovation, treatment for this came as a artificial stimulation, and from that this pacemaker originated. You see how technology is developed. First pacemaker, like a big box, whole room people used to do, and gradually in 50s, huge development in technology, that this young boy was saved by these machines. And now you know from today, the weight is 18 milligrams, like your coins. So this is the last 70 years what developments have been in this technology. So, in quickly, if we sequentially in 60s, one chamber was started Second chamber was started, rate responsible times, automatic adaptation came, and even the huge changes of this, like your technology. What are the problem? I will discuss in coming in 15 minutes, and 5 minutes I will take for the regarding the discussion. Sir, basically we must know that what are the basic indication, and all of we need. Who needs pacemaker? The basic question is that best indication of pacemaker is when there is a low pulse rate with symptoms, particularly symptomatic bradycardia, whatever the cause of bradycardias are. And you know, I tell you that just day before yesterday I was searching the net, and it was the Hippocrates who described in that time, as to more than 2000 years before, when your heart is less, people started fainting, getting convulsion. This was the typical picture 2000 years before, and the treatment has been done for this. So what are the symptoms? We all are knowing that whether pre-syncope to syncope, dizziness, seizure, shortness breath, palpitation, all are varieties of symptoms. But alarming are the basically alarming symptoms are, look, pre-syncope and syncope with bradycardia. If you are noticing pulse beat is less than 40, patient is having dizziness, alarm it. The basic message is that we have to investigate them. What is the cause? Why people are getting fainting? And that is for everyone, even for the public perception and this. And simple pulse examination. From Ayurveda, doctors used to treat through the nari. If nari is less feeble, very, very low, they are alarming, giving the alarming sign. So, assessment, we all know. How to assess? History, examination, ECG, Holter. Holter is the basically ambulatory ECG. Holter was the scientist who discovered this ambulatory ECG. And the honor of his name, Holter was given game. And new advances like recorder, even implantable recorder. Someone is having fainting, do not get in basal ECG. So this is the technology advancement when we are putting a loop recorder, and after 6 months, 1 year analyzing this. And adaptive test, graded EP study last 30 years, it has been very advanced in the future for electrophysiological study of heart, and gradually this is the one of the diagnostic tools for the coming year. Now we all know primary causes of bradycardia. 3 common indications for bradycardia are 1, sick sinus, 2nd, AV block, and 3rd, special conditions. We know sick sinus is variety of things. Bradycardia, arrest, pause, tachybrady, chronic incompetence, according to variety of Holter's finding, and we have to approach what is that. Yeah. Here we will see the sinus bradycardia. You see some variety of changes, arrest, you see there, here. Normal beat, normal beat, normal beat. There is a transient lack of impulse from the SA node, and there is a gap, and the second is 2.8 seconds. And normal criteria is that the second minimum, if it is more than 3 seconds, 3.25 seconds, it is one of the indication, and if symptomatic. So SSS, 3S, sick sinus syndrome, it becomes 4S, symptomatic sick sinus syndrome. It is one of the indication for pacemaker. And 4S, sick sinus syndrome, even in India, we have done a study in our hospital, in Central Hospital, and analyzed the cases of around 300 cases. Our most common indication was AV block in 55%, and 35% cases are the sick sinus syndrome. But in the Singapore hospital, they have analyzed the similar study. They have got more than 60% are due to sick sinus. But trend in our hospital and is again it is due to geriatric age group. The sick sinus cases are coming more and more patients, and we are getting lot of cases are there. Similarly, sinus pauses. Similarly, you say one of the important is tachybrady syndrome. Sometimes your heart is beating slow, sometimes fast. Sometimes slow, fast. You see the slow, slow, fast. It is again a very common condition of that. Similarly, this look for atrial flutter and fibrillation. You see this is typically of the fast atrial rate with the ventricular rate, atrial rate at around 30. Fibrillation with symptoms are leading to variety of changes for this. If we go for AV block, heart block, we see common first degree, second degree, third degree. First degree heart block and third degree AV vascular and AV block. These are the common day-to-day indications for heart block. How to diagnose heart block? By seeing clinical examination and ECG. ECG itself will give you the variety of change. I'll give you quickly in seconds that some slides. It is your first degree when there is a prolongation of only PR interval. Second degree, two types, MOBIS 1 and MOBIS 2. MOBIS 1 when there is a gradual increase in the PR interval followed by one drop, no QRS. This phenomena is Van-Kie-Wax phenomena, and this will lead to Stokes-Adams syndrome. Van-Kie-Wax was the first person who demonstrated it, and in honor of him, this was the MOBIS type 1. And similarly, MOBIS 2, when there is your PR is prolonged, normal, but there is after each 2, 3, 4, there are 2 P wave to 1 QRS, 3 P wave to 1 QRS, so 2:1 and 3 AV block. Similarly, if we go for the two common rare indication, this is a classical heart block. Everyone have seen the heart block for so many patients, whether there is a PP interval and QRS interval are separately beating. So normal the one basic fundamentals are when heart is working own pacemaker, it is 72 SA because it is beating with a heartbeat of SA node. If there is a AV node around 40s, if there is a ventricular around 20 to 25s. So the around 30 to 20 to 40 beats may be in between the heart rate. Similarly, we'll come to other, this rare indication of this. We all have seen so many vasovagal attack, but vasovagal attack is not a direct indication of pacemaker. It is one of the rare indication. We have to exclude it by variety of tests and this. But carotid sinus, we have gone for 2 cases in last 10 years when there is a huge carotid sinus hypersensitivity, and particularly during time of doing the saving, collar, patient fell down. So if there is a hypersensitive test followed by the varieties of test, and that is one of the indications for cardiac cases. But vasovagal, you know, at the time of so many cases, we all have felt in our one life here, near dear relatives suddenly fall. But that is due to vasovagal phenomena, and lot of causes are there. But rarely we have to exclude it. I have never gone in last 10 years any pacemaker in vasovagal syndrome. But it is the rare indication. We have to exclude whether it is the indication for the pacemaker. Now these are the indication. If we could, what is our pacing goals? Look, the pacemaker goal is 2, saving of the life and giving the quality to life. Now whole the phenomena is that when you are giving the life saving, that is our first target. Second target is that give the QOL. So basic goal, prevent syncope. Ideal goals, maintain, closely mimics the rhythm of the natural heart. That's why the preserve your hemodynamics and patient lifestyle should be as before here. So ladies and gentlemen, basically there is a myth. So look at this picture. Myths are that the older patients do not require heart rate adaptation due to they don't exercise. But the realities are even older patients require the same heart rate support as younger patients. Similarly, ladies won't require heart rate. But dear, she cannot see the watch this their own videos. Even they have a right to exercise for everything. Similarly, this is the myth, don't require same heart rate as men, but reality are they required even more aggressive treatment for that. So, rate responsive fitness, ideal for this physiology. I have told you it is a two purpose, save the life and give quality to life. So, benefits of rate response are many physiological phenomena for this. They increase the output, don't better quality of life, and this. So, the pacemaker stimulus, basically it is a stimulation device. We are stimulating the heart. If heart started with less, we are stimulating. If we will only stimulate single chamber of ventricle, what will be a problem? You see, this is the ventricle, this is the atria. You are putting one lead stimulating this area. So what will be the problem? That there is a ventricle to ventricle, ventricle to atria, and this intraventricular, this dyskinesia. I don't want to go in detail, but these are the three major concerns we are following. That what are the atrioventricular, intraventricular,
Dr.
dyskinesia?
Jha, please quick. Next speakers are waiting. Time is short.
Yeah. And these are the desynchronization of this dual chamber pacemaker, particularly for the desynchronization and this standard of care pacing, 6 sinus intermittent power pacing. Now I will come to this. What are the practice for the minimum RV pacing is one target, ideal. So, RV pacing of this mode, MVP mode is one of the possibility for this. And care of that, yes. What is the more than 30 lakhs people are in the world are having this. So, we see what are the problem, 30 lakhs and new technology is MRI. So, what happens to now problem? You see, the whole, if someone is having this and every 2 hours, 3 hours, one patient is put on that, we are denying the for the this. So this the advances in this technology in this field are this. What will happen to the interaction with this? The force, talks, vibration, arrhythmia, heating, and leading to the phenomena of this. The whole circuit will lead to the VT. So that's why in future, the challenges are cardiac arrhythmias prevention. So most of the pacemaker now is coming with the MRI resistant pacemaker. And this VT leading to death. So most of the MRI conditional pacemaker is the one of the recent advancement. And even lead, if there is a financial constant, we are putting only the lead, which cost only 3,000-4,000 more, so that in future is the MRI resistant. So you see the MRI resistant, and similarly there is a phenomena for the failure. Heart failure is one of the combating for that optimo sensitive of this machines is coming to prevent for the most of the heart failure phenomenon. Similarly, you see if there is a failure leading to formation of this butterfly pattern of that. because there is a lung accumulation. So that can be combat for the EM. So what is ultimately, if we are putting a lead in various ways, more than one lead, physiological targets are there, and we see the one in the ventricle. Similarly, there is a version of the variety of EM, and CRT is one of the for the different type of advancement, and that has been tried in last 4 to 6 months. One more, just one few seconds for the leadless pacemaker. Respected chairperson, this is the in future. So many trials has been done for the leadless. No need for lead, and so many centers have started. There is a small. This is the leadless pacemaker is coming now. So with basics, Dr. Ghosh is here, and in 74, we have a patient who is the longest life, and she treated last 40 years. In 74, it was been implanted, and all the 5 generation legacy we are acquiring. I did the operation for 2 times in 2003 and 4. This Mr. Mitro, and here this patient was operated in 70s in Dr. Debu Mitra and their team in SSKM hospital, who came to our hospital in 74, and followed by 3 times operation. Sorry, this video is not working, but here we recently operated this patient, and we live 5 times operated, and he is alive now. He is one of the longest patients on with this patient. So ladies and gentlemen, pacemaker is one of the life-saving device. The cost is, in railways we are getting only in 40,000 rupees. Outside is 1,50,000 which is keeping in this. It is a very cheap device and life-saving device, and it gives life to this and this phenomena of this. And if we conclude with that, it is the technology which is advancing. We have to follow them from the end to this, and newer advancements are coming. We have to fight with the technology. Always, never one battle is won without having well-equipped and advanced equipment. So, ladies and gentlemen, the message is that we have to tackle with the technology, and our railways have an enormous capacity. Newer generation will come, and we'll fight with them, we'll cover them. Thank you very much.
Thank you, Dr. Chai. You've almost covered the entire topic quite well. But there are just 1 or 2 issues which I would like to highlight. Of course, he's touched them. If anyone asks a postgraduate here as to what are the advances in pacemaker technology, the advances have come up with the aim that since you are putting in a device, let the device work to its maximum. Keeping that in mind, this Optivol pacemaker has come up, because if it is for a pacemaker with a heart failure, the moment the lungs start imbibing fluid, there will be an impedance difference, and the pacemaker will start giving auditory warnings to the patient that he has to consult a doctor or increase his diuretic load. This model is available in the country. We have used it on our railway patient. Next is the biventricular pacemaker, which is given for dilated cardiomyopathy patients, where there is a dyssynchrony. This is a biventricular pacemaker, very much available. We have used 10 pacemakers over the last 3 or 4 years, and the patients are doing well, excepting one who has died. Third is the technology of rate responsiveness and adaptability. He has said MRI compatible pacemakers have come very much in there, and in this year's tender we are procuring MRI compatible pacemakers for a small section of the patients. Fourthly is the leadless pacemaker, which he has talked about, because all of us who are into pacemakers, we know that the problem of pacemaker arises from the pocket infection, pocket erosion, or the lead fracture. So give away with the pacemaker at all. The pacemaker would be converted to a small AAA sized battery, and it would be directly inserted into the right ventricle. But there is a problem with this method, because once the pacemaker needs a replacement, how many batteries can you keep on putting it into the right ventricle? So the future is very much in the pipeline, maybe another decade. Biological pacemakers are coming up, whereby the heart, cardiac, any cell of the body through stem cell would be converted into a pacemaking cell, and that cell would be somewhere in the sinus node, so that without any device, the automatic cardiac myocytes will take up the action of pacing activity. So the future is very bright for pacing, Pacemakers have been converted to ICDs. Pacemakers have been converted to, as he has mentioned, loop recorders, whereby we are unable to diagnose the cause of the syncope. So we just introduce a small pacemaker-like thing, which is active for 6 months. For 6 months, it will pick up everything, and we can assess. So the pacemaker industry is doing great work, and we are all in for a very good time through pacemakers. Thank you so much.
Now may we request Dr.